protein.
This is used in the diagnosis of the hepatocellular carcinoma.
So it's for hepatocellular carcinoma. Any other indication? So you could be asked, apart from hepatocellular carcinoma, what is the clinical importance of alpha-fetoprotein aside the hepatocellular carcinoma? Any other indication?
Chronic hepatitis.
Come again.
Chronic hepatitis or cirrhosis.
So we use alpha-fetoprotein for chronic hepatitis. Any reference? Who can help me apart from the hepatocellular carcinoma? Any other indication for alpha-fetoprotein? So when a pregnant woman, a lab test is done for a pregnant woman, and there's increased concentration of AFP, which is alpha-fetoprotein. When you see this higher concentration in the blood of a pregnant woman, then it's a suggestive of neural tube defect. So note this. Is it clear?
Sir, please, can you come again? My network.
I'm saying, have you changed your network? Or is the same network?
It's the same, but it's stable now.
Okay, so I'm saying that for alpha-fetoprotein, that's the last parameter I'm talking about. For alpha-fetoprotein, it's an indicative of hepatocellular carcinoma. When you want to check cancer of the liver, AFP, alpha-fetoprotein, could be considered. Another thing that you should know is that when pregnant woman, a blood test is done for a pregnant woman, and you see higher levels of AFP, alpha-fetoprotein. So increased concentration in pregnancy. When you have AFP in the blood of a pregnant woman, higher concentration, then it's a suggestive of neural tube defect, which is as a result of when a pregnant woman is not taking folic acid, can easily develop these conditions. So when pregnant woman comes up higher of this, then it's suggestive of NTDs. Is it clear?
Yes, please. Thank you.
Okay, so let's move on to this. So what else? We want to move on to clinical manifestation. And for the clinical manifestation of patients with liver disease, we have non-specific symptoms and specific symptoms. So in other words, I can say that you have subjective and objective symptoms. And of late, I'm seeing this, and be careful about this. If a patient comes with UTI, UTI, they can ask you about what will be the sign, what will be the symptom. Last year, there was a question about this. So UTI, if I'm asking UTI, what will be the sign, what will be the symptom? Who can tell me? Diabetes, what will be the sign, what will be the symptoms? Normally, when we are learning, we lump them together. We say signs and symptoms or clinical manifestation. But of late, they will tell you what will be the sign, what will be the symptom. So who can tell me that for UTI? Who will try? For UTI, what will be the sign, what will be the symptom for UTI? So UTI, if asking UTI, what will be the sign, what will be the sign, what will be the symptom?
Sign, drastic weight loss.
So what is it UTI or diabetes?
Please, diabetes.
Sign for the weight loss. What will be the symptom? What will be the symptom? Okay, so find out. If you can't answer this simple thing to me,
Dr. Attakorah,
right?
please, the symptom can be the polydipsia, polyphagia,
I'm listening.
polydipsia, polyphagia, polyuria.
These are the symptoms. That's what you are telling me. What will be the sign?
The sign will be elevated blood glucose.
Somebody is saying drastic weight loss. So if a patient comes with HIV, can the patient come with drastic weight loss?
Yes, they can.
So how come that I'm talking about diabetes and you are telling me the sign should be drastic weight loss? So if I'm talking about the sign, what do I mean? If I'm talking about the symptoms, what do I mean?
So please, the sign is what the clinician can see. So maybe in terms of the labs, and then symptoms, and that's the same as the objective data. And then symptom is what the patient is reporting.
So for the diabetes, what will be the sign?
So there can be increase in glucose and the glucose level.
What should be the sign? Hey, learn Don't talk about this generalization. Learn to say this specific. What will be the sign? For diabetes, what will be the sign?
Fasting blood glucose above 7 millimole. Random blood glucose above 11.
Mhm.
And HbA1c of greater than 6.5.
So this is an objective data, and this is the sign. Don't talk about drastic weight loss. Better, don't talk about drastic weight loss. So link the sign to the objective data. And the objective data, it's specific. Objective this data will point to the condition. So if I'm talking about malaria and I want the sign, link it to the objective data. Don't talk about things that could be linked to other. If you are talking about drastic weight loss, other things will also come with drastic weight loss. Link the symptoms to the subjective data. Where things are blurred, you cannot say that subjective data could be linked to other conditions. So if I'm talking about drastic weight loss, it could come from other conditions. We'll also give you drastic weight loss. So learn about that. Don't right?
Attakorah, please, what about in a situation where some of the symptoms can also appear as signs? Do you state it under both?
I'm saying that when I see MPs, when I see high HbA1c, high of that, what will come into your mind?
Diabetes?
Do you doubt it?
No, please.
When I see UTI, when I see leukocyte esteroids, do you doubt it? Can you get to me?
Yes, please.
Do you doubt it when I say that this patient is having UTI because leukocyte esteroids is positive in the urine analysis? You say it's if a doctor diagnoses UTI based upon this, can you say the doctor is wrong? Could be other thing. You get what I'm saying?
Yes, sir.
Yes, sir.
What you should know is that we can talk about objective data, and that objective data is something that you can measure. It's something that you can via examination, and all these things should point to a specific condition. If a doctor is measuring something, it's examining a patient, it's doing lab, it should point to a specific thing. If the lab comes and it's like, you cannot say it's this. If after the examination, you cannot say it's this. You did the x-ray and the doctor can't say it's this, then it does not make it an objective. So note that link the objective data to the sign, and the objective data and the sign should point to it. So if a doctor is It's examining a patient. It's not coming out with any objective thing. It doesn't make it a sign, or it doesn't make it an objective data. I was asking this confusion question, and let me ask you whether you can answer. If a patient comes with infection, a patient comes with infection, and I'm asking you about the objective data, what will be the objective data? General infection, what will be the objective data for that?
Elevated white blood cells.
Elevated white blood cells. Now, is UTI an infection? Is UTI an infection? Yes or no?
Yes.
Yes.
Yes, it is.
So if I want an objective data for UTI, can I say high WBC? Can I say that?
No.
Why no?
Because it's not only UTI that will come with elevated white blood cells. There are other infections that can also come with an elevated white blood cells.
So at a point, we are saying that high WBC is an objective data. Now at a second point, we are saying no, it's not. You get it? So infection, if I want a general infection, I'll be looking at WBC as an objective data. But if a patient comes with UTI, then I will not look at the WBC. When you check the WBC to be high. But if I want specific, something that is linked to UTI, and something that will be pointing to UTI, then I'll be talking about nitrite. I'll be talking about leukocyte esteroids, and that will point directly toward UTI. So the moment I see analysis and I see positive leukocyte esteroids, I see nitrite in the urine, then it's pointing toward UTI. It's infection, all right, but here the objective data becomes the nitrite and what? Or the nitrite or the leukocyte esteroids. But if I'm talking about infection in general, then I'll be looking at the WBC. Please, am I making myself clear?
Yes, sir.
Is it clear to everybody?
Yes, sir.
Please.
No or yes? No or yes?
Yes, sir.
No, sir.
Where? Which side are you having issue with? The person saying no, sir.
Sir, please, my network was unstable.
When you do that, it will be pendulum. I'll go, and my network is unstable, then I'll come back, and I'll be at a point. So put those points, then you ask your friends. If you want us to come, you start. Then it will be a pendulum. I'll move, and somebody also say my network. Then, class, do you get me? If your network is on, put that where you put that point down, and you can ask your friends later, such that we can move on. So, which area specifically?
Sir, please, can you explain the response you gave us? Yes.
I'm saying two things. I'm saying when you talk about objective data or sign, if I say the patient is having fever or high temperature can be an objective data at a point, but it's not all the time. It's not all the time. So if I say high temperature, does it make it objective data or subjective data? Does it point to malaria? If a patient comes to and you see the patient is having high temperature, does it point to malaria? Yes or no?
No, please.
But if a patient comes with MPs, does it point to malaria?
Yes, sir.
Good. So what I'm trying to say is that now if I'm talking about infections and I'm asking you about an objective data for infection, an objective data becomes elevated WBC. But now if I become specific, I tell you the patient is having UTI. UTI is infection. But if I'm asking about the objective data for UTI, you won't talk about high WBC. You want to tell me, because I've mentioned UTI, you'll be telling me that no, I should look for what? Leukocyte esteries. I should look for nitrite. This will be a specific thing towards UTI. This will be direct, pointing towards UTI. But if I say high WBC will not point to UTI. But UTI is infection. But it will not point to UTI. But if I say nitrite will point to what? Nitrite will point to. So what I'm trying to say is that when you are learning of late, don't lump them and say that this is for your own good. When any condition that you are learning, and break it down to sign. Don't say clinical manifestation or signs and symptoms. Don't lump them. So look for the signs and look for the symptoms and learn it. If I'm talking about Samuel, Amma, can you mute your Atia?
Hello, hello, Dr.
Can you tell Amma to mute, please?
Yes, please.
So when you are learning, if I ask you pneumonia, what will be the objective data for pneumonia? What will you say? Or the sign for pneumonia, what will you say? Pneumonia.
Participation in the chest issue.
So what do you use to check that? What do you use for pneumonia? How do you diagnose pneumonia?
With the chest.
Using the chest X-ray.
Use chest X-ray. Using the chest X-ray. And that would point to it. So when I'm talking about pneumonia, I'll be using the chest X-ray. I will not talk about pain at the chest. I'll not talk about difficulty in breathing. All this becomes what? Symptom. So please, this is just it's just a passing information. Note that. Don't lump these two together. Make sure you know. Okay, so we're talking about alpha-fetoprotein.
Please, sir, please, a bit confused. I need some clarification. So something like the pneumonia, I was thinking that the chest X-ray is also indicative of like other conditions. So stating that as a
Other conditions like
as an objective data.
other conditions
like tuberculosis, like TB. So I was thinking of probably a sputum culture sensitivity test will be more specific.
Oh yeah, dear. Abina, dear. Why? So you do a sputum test and you give you what? The sputum test will give you what? And how do you test for tuberculosis? Abina, can you tell me how do you test for tuberculosis?
You can do the sputum test for TB.
You do a sputum test. What again? Oh, hurry up.
The gene expert.
Gene expert. Uh-huh.
Yes.
So if I'm doing a sputum
Yes,
test, if I'm doing a sputum test for pneumonia, can I have a diagnosis? So listen, for diagnosis of pneumonia, we use X-ray to diagnose pneumonia. We use X-ray, please. The doctors will not use sputum. The doctors will use X-ray to the diagnosis. So take note of that. Why? Abina, if you are asked about the diagnosis for pneumonia, it's X-ray. That X-ray can also help you to diagnose TB, but it's not. We use other labs for TB, but for pneumonia, it's what? X-ray. Okay, so for this, just by the way, so for if a patient, a liver patient comes, what will be non-specific clinical manifestation? Non-specific clinical manifestation, and that is subjective data for patient with liver impairment. What could be? Who can tell me about, if I told you to list 5 non-specific symptoms or clinical manifestation of liver disease, what will be?
Weight loss.
So there could be weight loss.
Fatigue.
Fatigue. Good. What again?
Fluid purity.
Come again. I can't hear you. Your line. Your line. I can't. What again, please?
Abdominal discomfort.
Abdominal discomfort. Good. Abdominal discomfort. What again?
Yellowing of the whites of the eyes.
You're talking about yellowing. Then you are becoming more specific. Please, do you get it? The moment you are getting yellowing, it means that the liver is not working and it's pointing to. If I say non-specific, the fatigue, heart failure will give you a fatigue. Anorexia, abdominal discomfort, weight loss, weakness, all these are non-specific. If you want to be specific, what are some of the specific symptoms? Specific symptoms.
Sir, jaundice.
So join this. That is yellow coloration. Becoming specific. Into your mind. Nothing will come into your mind. You won't think about liver. Because heart failure can give you that. But the moment you join us, then you'll be thinking about it. Your mind will go to the liver. So we have it again. If I ask you to mention specific symptoms of liver disease, about 5, you should be able to mention it. And this, what again?
Pruritus.
Ascites.
About ascites. Talk about ascites. What again?
Encephalopathy.
Talk about encephalopathy, hepatic encephalopathy. What again? Hurry up. Something. If a question is asked, mention 5 specific symptoms. You should.
Hyperpigmentation.
Come again. Somebody was talking about flapping, hepatic flapping. So flapping is there. What again? What again? Flapping is there. What again?
Hypoglycemia.
When you say hypoglycemia, I will not side with you. Why? Why? Who can justify this?
It's the sign.
No, I'm saying if it's not specific.
It's not specific.
I'm saying specific symptoms. When I talk about jaundice, you say jaundice, and the moment I say jaundice, you think about what? Talk about ascites. Talking about flapping. These are more specific. If I talk about hypoglycemia, then my mind will be going to what? Going to diabetes more. But a liver patient can also come with that. But it will be difficult. difficult for a patient to say that I am having a liver weak and therefore I've developed hypo. But it would be easier for a patient, a diabetic patient, to go into hypo. Easier. To be easier to say that hypoglycemia is linked to hypo more than linking to it, a liver disease. Who can explain this? Why I'm saying that? Who can do this for me? Do this explanation for me. It's to be easier to say that a diabetic patient will go into hypo than to say that, oh, a liver patient is going to hypo. Who can do this for me? Oh, hurry up, hurry. Hmm? Lads, can you help me with us? Who can explain why I'm saying, if I'm saying discuss this, it's easier for a diabetic to go into hypo than a liver patient to go into hypo? Who can help me?
It is inappropriate to say that a liver patient would present with hypoglycemia because blood glucose levels can equally be maintained by the ingestion of exogenous glucose, by the ingestion of glucose. But then it's more appropriate to say a liver impaired patient can easily go hypo because there isn't that internal checks of glucagon causing the release of the breakdown of glycogen whenever blood glucose levels are low.
Can you come again? Sylvia, can you come again?
It is inappropriate to say that a liver
I'm saying it's easier to say that a diabetic can develop hypoglycemia than to say a liver patient is developing hypoglycemia. You get it?
Sir, please, can you come again?
I'm saying it's easier to say that, oh, a diabetic patient has developed hypo than to say that a liver patient has developed hypoglycemia. You get it? Okay, so I think it's easier. This explanation is easier to just tell me A, B, C, D. In a liver patient, who can tell me the source? The body can get glucose from other sources. Who can tell me?
From the breakdown of muscle. Is it what?
We're talking about breakdown of muscles. Asking you about the other sources of where the body can get glucose. You're telling me breakdown of muscles. Please, don't rush.
Glycogen stores in the liver.
The liver is impaired. So, can you tell me other sources by which the system can get glucose? Other sources.
Gluconeogenesis.
Do you know what? Learn to do this. If you don't take care, you say, hey, I've answered the question well. Be careful, please. I don't want anybody to fail. So listen to the question. And when you're answering the question, be careful. Don't rush. I'm saying this. The liver is impaired. I'm asking you other sources by which the body can get what? Glucose. This thing you should be specific. Somebody is saying breakdown of muscles. The liver is impaired. Tell me that.
Ingestion of oral glucose.
So oral glucose, what's again? From the body. From the body.
The kidney.
So it will be what? It will be what? From the kidney, you are right. So it will be what? The body will obtain glucose from the kidney and it's through what? Renal gluconeogenesis. So the body will be getting glucose from renal gluconeogenesis. You get it? And where again will the body gets glucose? I've done this with you. You have done diabetes. And so please, where? We have mentioned renal gluconeogenesis. Where again? Hey, class. Where again can the system get glucose? Apart from exogenous. Breakdown of what?
Glycogen.
Breakdown of what?
Glycogen.
What? I am still not happy. I ask a lot of questions. Why? Because I want to know the way you answer questions. And still, you are still generalizing your answers. You're still generalizing your answers. Please. Glycogen. You haven't answered the question. So tell me, I'm saying that apart from exogenous glucose that will be given, apart from renal glucose, you said gluconeogenesis. I wanted you to specific. Somebody said kidney. So renal gluconeogenesis. Renal gluconeogenesis. What again? Where would the body get glucose?
Sir, please, the body can also get glucose by glycogenolysis from the liver and then stored glucose in the muscles.
So the liver is impaired. So I don't want you to talk about the liver.
Okay, so sir, from the stored glucose in the muscles.
Muscle. So the muscle glycogen. Then when you have to be specific to say muscle what glycogen. Conversion
Yes.
glycogen to glucose from where? From the muscles. That's why I'm saying that it will be difficult. It will be easy for the diabetic to go into what? To go into hypo. Patient can go from these sources. But if a patient is
Okay, so
on
sir,
insulin,
from the
and is
stored
going
glucose
to
in the muscles.
muscle. So the muscle glycogen. Then when you have to be specific to say muscle what glycogen and for liver, so not thing. So let's go. If we talk about ascites, you talk about jaundice, you talk about hepatic flapping, all these things would gear our. So now let's talk about things that normally comes in your exams. Let's talk about these things. Please take note of this. Let's talk about, if I tell you to mention some of complications that will ensue if a patient comes for liver disease. The conditions that we see at the ward, the common complications that we see at the ward when the patient comes with what? Comes with a liver condition. So what are some of the things that we see at the ward? We see at the ward. Plus, what are the conditions that we see at the ward?
Variceal bleeding.
So when we talk about variceal bleed, what again? A liver patient.
Sir, please, we can also talk about the hepatic encephalopathy.
Hepatic encephalopathy. I'm going to ask you, hepatic encephalopathy. What again? What again will the liver patient be coming with?
Ascites.
Ascites. So ascites. The fourth will be what?
Spontaneous bacterial peritonitis.
Good. SBP. What again?
Portal hypertension.
So portal hypertension. What again?
Anemia.
You talk about anemia. What type of anemia would you expect from a liver patient?
Anemia of chronic disease.
Anemia of chronic disease. Good. Anemia of chronic disease. What again? What again will a liver patient be experiencing?
Dog, osteoporosis.
There could be osteoporosis. Good. Osteoporosis. Any other?
Hepatorenal syndrome.
There could be hepatorenal syndrome. Any other?
Winnicke-Korsakoff syndrome.
So Winnicke-Korsakoff what? Syndrome. Good. And this syndrome is as a result of what? This syndrome is as a result of what?
Lack of vitamin B1.
Lack of vitamin B1. And vitamin B1 is called what? Thiamine. So should we give thiamine to every liver patient that comes?
No.
Should we give thiamine? So anybody that comes with liver disease, we give time.
No.
So when do we consider timing?
When the liver dysfunction is as a result of alcoholic.
So when the liver is the cause of the liver disease is due to alcoholic liver cirrhosis, then we think about giving what time. We talk about this later. So all these we talk about priorities. All these are clinical manifestation or complications of liver. There are certain things that I know you have done in your various schools. I don't know whether I have Legon people among us. Have you done liver? Do you have Legon people among us?
Yes, please.
Did you do liver at school?
Yes, please.
Hey, the same people one are saying we did, other than saying no, why?
If we did it at level 200, I think that's right.
You did it at level 200. Papa. So because you did it at level 200, we are saying that you didn't do liver. Hold on for me. Hello? Hello? So because you did it at level 200, you are telling me you didn't do it. Central, did you do it? Central guys, did you do it?
Yes,
Yes or no? Hello?
yes, we did.
I did. Ombejina Chiranami entering. So understand it. I am not doing liver from A to Z. I'm taking the salient points. You need to understand, please. The salient points you need to understand. So let's now. These are some of the complications, the common complications that we'll be seeing. Patient to be coming with variceal bleed. Patient to be coming with ascites. Patient become SBP. Patient be coming with portal hypertension. Patient be coming with anemia, osteoporosis. Some will be seen easily. Others will take a longer period for you to see. Osteoporosis will take a longer period for you to see. And ascites, encephalopathy, variceal bleed could be seen easily. When a patient comes with liver disease, be seen easily. But let me say this. All these complications, hold on. So all these are complications. All these are complications, but let me say this. All these complications that we are talking about will start from the portal hypertension. Almost these complications, variceal bleed, encephalopathy, ascites, will start from the portal hypertension. The portal hypertension. I was asking you, I know Key University, guys among us, you have done it. You have done liver. University guys, have we done liver? And you would see they did it at level 200, and because of that,